Welcome, everybody. Today is September 16th, 2025. I'm super excited to have with me and Reza here today, Dr. Efrem Castillo. Efrem was our boss's boss at Optum, and he was probably the most fun person we got to interact with there. So, Efrem, welcome. Thank you so much for talking with us today.
Absolutely. Thanks, guys. Good to see you.
So Efrem, tell us, why don't you just start a little bit by telling folks kind of who you are, what you're doing now, and then we'll go back to kind of your origin story.
Oh, wow. Okay. Efrem Castillo, a family doc for many years. And right now I'm working at an organization named Rendr, based in New York City, who's primarily focused around Chinese American community. EVP, really more kind of leading, guiding, consulting almost in that role.
Amazing. So take us back to I'm actually like I don't know your story. So like, where did you go to med school, residency, and then what happened after that?
Oh, Alex, do you have enough time?
Yeah.
No, this is I love this. I love my own personal story, don't we all? Went to medical school in San Antonio. I actually wasn't planning to go to medical school. I was thinking I was going to go to pharmacy school. And someone said, you had to take that MCAT thing. And so I did. And luckily, I did well enough to actually apply and get in. And I went to San Antonio. I grew up in Houston. Went to medical school and loved everything. Like, people like say, oh, medical school was rough and it was terrible. And it was. But in retrospect, it was kind of fun, right? You got to do all these things. You got to meet all these people. And you learned all the time. And it was challenging. And so in my mind, people say it was rough, but it was rough, but it was a good, fun rough, if there's such a thing. Started a primary care group while I was a second-year resident family practice. In those days, hospitals funded quite nicely. They had quite a bit of money to expand their base. And so we opened 5 clinics before I actually left residency. And we were able to man those. We had hospital guarantees and subsequently grew them. Started a hospitalist company, one of the first ones in San Antonio, actually the second one. Great story there. Learned capitation the hard way. I decided that I would take a cap in the late 90s of $8 PMPM for Medicare business. Now, if you do the math roughly, and there's 13 hospitals and you're one guy, 2 guys, that math doesn't work. It's 30,000 lives. That was about 30 admissions, discharges, and people to round on over 13 hospitals a day with 2 folks.
Are you kidding?
Oh my God.
Yeah. So you can do the math when you're silly. You're like, oh, $8 times 30,000. That's $240,000. I'm going to be rich. And then you realize there's not enough money there to fund and man, and there's not enough. It was a very, very traumatic but learning experience. And after that, did that for a while. We sold the company. Went and was a CMO in Houston right at the turn of the century for a small health plan. And so wanted to learn that side. Came back and worked with another at-risk group here in San Antonio. And we started taking risk. And I was not at WellMed, but subsequently started a contract with WellMed and went to WellMed. And all of this time, I was doing everything you could imagine, Alex. Hospice, medical director for a home health, medical director, what was called physician advisor for a hospital system. It was actually HCA. You name it, I did it. Insurance, physicals, I did everything. Urgent care, I did everything.
Yeah, let's pause there. There's so many of our listeners who are in that early stage, like what you're describing, right? And they're like, they have one job, they're thinking about taking a side gig, or they have 1 or 2 side gigs. So like, walk me through in the very early days when you say you're doing everything, and we've all done it, Alex and I, right? Like, how do you decide what's the next thing you're going to kind of do on the side of your desk? I mean, you have a life, you have a family, like there's other things going on. Like, how'd you do it?
Well, I was much younger, had a lot more energy, number one. Number two, I was much better than at parsing time. Like I made a point, like, I got up every morning at 4. I went to the gym. I went to the hospital. I went to the clinic, I went back to the hospital, and then I would do something for an hour or two before I went home. And I was very diligent. So that was the first, like, just the mechanics of it. The second thing, I think, what you're really asking, Rez, is how did you like decide, like, why would you want to be the medical director of a home health? Like, who wants to do that? Why would you want to do, be sniffist? Who wants? The reason is because I wanted to learn. I really wanted to understand the system. Because, if you're doing a thing and you're going through the mechanics of a thing, you're doing an activity in this space in healthcare, you often don't know what happens after it leaves your desk or your room or your facility. Where does that home health request go? How does it get paid? What happens when someone gets enrolled in hospice? What happens when someone goes to a SNF or a nursing home? Who takes care of them? All of those things I really wanted to understand, and it made me feel, and this is a really good example in my mind, the people that get the best care in a nursing home is not necessarily related to the nursing home. It's related to how often somebody visits them in the nursing home. They can be in a really not so nice nursing home, but if they have a family member come by every day at different times of the day, they get much better care. And it's not a negative against anything. It's just
Right.
there's somebody there to advocate in that example, right? So there's a lot of those experiences I learned, and I was able to translate that into my practice, but also it helped me just understand the system. So rather, that's how I kind of decided, like, I don't know how this thing works. And they want me to, like, who knows how a physician advisor works in a hospital?
Efrem, how did you even get those roles?
I was a little bit boisterous. I used to say this thing when I would give talks to folks. Say when you have the opportunity to learn, and it has to make sense. Don't get me wrong. Don't say no. Don't say no. Like, if you have an opportunity presented to you where you're going to learn or grow or be challenged, don't say no. The worst you can do is do it for 90 days and say, you know what, this is not working for me for whatever reason. But at least you know that thing wasn't going to work. But I was one of those guys that said, yeah, I'll try that, and like, and it worked out. Like, I was able to do it. You could argue that maybe you weren't as discerning as you should have been, perhaps, but the experiences that I had doing those things, I don't think you could have matched them otherwise. Like, you couldn't read how to be a medical director of a home health company in a book. Like, there's just no book. Like, the
Right.
mechanics of the nurses not showing up and them calling you, what do I do?
Yeah.
How do you be a physician advisor to HCA? How do you, like, those things? Nobody's going to teach you unless you actually, like, sit there and do it. My experience.
100% agree. I spent a year as a medical director of a methadone clinic early in my
Exactly.
career, right? You're never going to learn how addiction works, actual SDOH, how it impacts people's lives, unless you're like knee deep in a place that's seeing 1,500 patients a day, that looks like a DMV. Like, that's the fun and joy of like bouncing around early on, but also looking back and revisionist history. Like, those are the building blocks that take you to the next step. So
Exactly.
take us back to the story, the day job. What was the kind of the next step?
So I started doing some work in a medical group here, and we got a couple of really nice contracts. And then I opened my own clinic. We were able to grow quite nicely, and I was working 1099. I love to call it this, the 1099 work. I was doing 1099 hospitalist work for WellMed, actually, who is and was at that time one of the premier value-based organizations taking full risk for many, many moons. And I started being their hospitalist in one of their downtown pods. And so had my clinic and was doing hospitalist and just kind of grew in that role, and was faced with a kind of difficult position. So remember, I was a physician advisor for HCA. I was a hospitalist. I had my own clinic that was growing. And one of the hospital systems approached me and said, hey, we would love to buy you and have you work for us full time, and be able to, we'll buy your clinics and you'll just work for us nationally full time. And man, I was like, wow, this is awesome. I'm in. Where do I sign? But I talked to two very important folks at WellMed, and one of them, who I don't think will mind if I say this, Dr. Rapier said, who's the founder of WellMed, said, do you want to, and he didn't say it in it, so folks listening don't think this in a bad way. He said, if you work for a hospital system, your role is a little bit different. If you work for a value-based system, your role is to keep people out of the hospital, right? Hospitals have a role and they have a significant part of the healthcare system, but do you want to be trying to improve value-based and keep them out of the system? Or do you want to, work in that kind of broader system? Now, granted, I had never worked in a large system, so I was like, wow, I don't know. And he said, I can't pay you as much. I can't pay you as much. And I thought, man, this guy's killing me here, right? So I went to work for WellMed. And at that point, I kind of transitioned from less clinic work to more administrative work, did business development in Florida, opened up to some of the Florida markets, and did did STARS, did risk adjustment, all those things in the value-based system around 2007, 10, or I can't even remember back then when that stuff was really getting cooking. And after a while, we had the first 5-star plan in Texas, actually. And United came in, we had to do what I call a dog and pony, where you had to wear a tie. And subsequent CEOs through the system came to visit WellMed, and they asked us about STARS, and I was the spokesperson for STARS, so I got to give these lovely presentations. And I remember the last one, the CEO was coming down, and our president came and said, we have to give this presentation one more time. And I was like, dude, do I have to wear a tie again? Like, this is killing me, man. Because, we're physicians and clinicians, and we're running and gunning, and we weren't office based. We were out in the field. We were talking to folks. Like, it's really difficult, especially in Texas, to wear a tie all the time. So yeah, he said, yeah, you got to wear a tie one more time. So the CEO and a whole slew of folks came down, and I presented this, how we got to 5 stars and what we were doing. And a couple of weeks later, he calls me into the office and he says, hey, so we were a very cordial group. We would banter like we're bantering now. We'd have deep discussions. We would get stuff done. But it was a good environment. So when he said, hey, can you come to my office after one of those meetings? I thought, what did I do wrong?
Wait, are you talking about George right now?
I'm talking about the president, Brian. But we were in one of those meetings, and he called me into his office after, and he says, yeah, sit down or something, and closed the door, and I was like, oh man, what did I do wrong? And he said, they want you to interview for the CMO for UnitedHealthcare. And I used a bunch of inappropriate words and say, this isn't April Fool's, stop joking around, come on, we're cool, like, this is not funny. I thought he was joking, and seriously, he wasn't. So I interviewed for the role, and about many moons later, because in those roles, they take a lot of time and a lot of vetting and a lot of multiple visits to Minnesota. I went to be the CMO for UnitedHealthcare for Medicare and Retirement, so nationally, which was a...
Yeah, let's dive in a little bit, right? So you're here in San Antonio, right? You're doing amazing things. I mean, total reach is what, a couple 100,000 patients at the time. And then all of a sudden, United, who, I don't know, at the time probably had 6-7 million Medicare Advantage lives, right? Like
4 million, but yeah.
4 million, right? But now it's bigger, right? So what are you thinking? How are you interviewing? How are you thinking about this? How are they evaluating, right? Because a lot of our listeners are also kind of in that medical director looking to be a CMO, something bigger, something different.
Yeah.
How did you leverage the amazing work you were doing in quality into something so big, so national? I mean, it's like the number one guy for the largest payer in the country.
And did you have what were you afraid of? Did you have an imposter syndrome feeling? I know I would have.
I had a little bit of imposter. I wasn't as afraid. I was really, this is going to sound silly, but I was intrigued. I was like, what are these guys looking for? Number one. Number two, I was really trying to understand. So when they were interviewing me, obviously I was interviewing, like, what is important to you? What would success look like for you? How would you think about uh, creating a better health plan? You know, I'm obviously, and I'm a clinician, and a lot of these folks are not. So it was understanding what makes them, I'm gonna use a not right word, what makes them happy, what makes them, maybe that happy is not the right word, what makes them successful or feel successful, or that we are being successful. The other piece for me was, to your point, Reza, wow, this is a lot of lives. This is a lot of theoretical influence. How can I take something like this and make things better for people? And it sounds silly, but like, is it prior auth? Could I look at prior auth? Can I look at, how we make things easier for patients? Could I look at benefit design? Those kind of things. So part of my brain was, this is really cool. Is there something I could do that's bigger? What are the things that's going to be important to the employer, any employer? Like, what is the thing that they really need? And then as you go through these interviews and through this process, it's trying to understand how you would approach it. Because they would ask you, like, what are you going to do? How are you going to do that? And obviously, when you think about it, and as clinicians or even business folks or others, there is I'm not going to call it a rubric, but there is somewhat of a rubric where when you're placing you got to get the data. Like, you have to understand what the data, but you also have to understand what the problem, what you're trying to solve. And then you go through, so you can start to formulate a somewhat coherent response to many of the questions, but you also have to really be cognizant of what they're truly asking, because a medical group, hospital system, health plan, go on and on and on, are way different in their desires. It's the way it is. There's nothing wrong with it, but it is because they have different constituents and different kind of people they're beholden to. So,
Efrem, when you're that high in a major health plan C-suite role, to what degree are you being told what to do versus you have to on your own figure out, like, okay, what are our top 5 priorities going to be this year? Like, how do you even figure out what to work on?
it's kind of that idea, Alex, where we have a priority where we would like to improve benefit design, but we don't want to change our bottom line. Or we need to hit an affordability target of X. I'm not going to tell you how to do it.
Yeah.
You have to figure that out. We need to mitigate readmissions.
Mm-hmm.
Right? Affordability, but it also has stars, right?
Yeah.
I would, like, in your head, I can see both of you guys are like, oh, I know what I would do with that, right? You're thinking already, right? But you'd have to go, okay, now let me figure out, okay, what does that mean? What's the impact? What's the cost of the opportunity, right? Because if I hire a whole team to do transition work, that's going to cost.
Right.
So those things. But that's what you'd be told, Alex. You wouldn't be said, "Here's a program, go do it." It was more of, "Here's a broader goal.
Yeah.
We need you to figure out and not only figure it out, but lead it." That's the other piece. So there's 2 pieces there. One is figure it out, and then one, garner the troops, if you will, to lead through each of those initiatives.
So if you go back to that time of that 4+ million lives, what percentage of them were delegated to a medical group versus still at the time being managed by United directly?
That time, not as many were delegated. I can't remember the exact. I'd want to say maybe 1.2, 1.25 to 30% were delegated, maybe. Delegation in 2015 it was obviously increasing, 2016, but it wasn't as high as it is today.
So then if you think about, there's a 2-tiered approach to driving impact, right? There's the leading and suggesting and things that the medical groups end up doing their own programs, and then there's the stuff that you guys are actually building and funding and rolling out, right? Like it's still a monumental task to move readmissions by 1% for 4 million patients with multiple different things underneath it.
Yeah. Yeah. And I think that's where it's important in any role to kind of look at the broader kind of environment, because you don't want to do something that is negate someone else's work. That would be no good. And if this is going to sound, if you can leverage and understand what someone else is doing, like have that open mind. Like, man, maybe they're doing it better. How are they doing it better? Let me get in the weeds of how they're doing it better. Oh, they have a relationship with the hospital. How'd they create that relationship? Oh, they've got a medical director that meets with that hospital CMO every week. Oh, well, that's how they got it. I mean, those silly things, kind of pseudo making them up, but not. That's where you can actually take those roles and make them kind of, I think, more powerful, because you're not like stuck in this little box. You're like, whoa, I'm going to really try and expand that.
Efrem, there's a lot of docs who are interested in getting into some sort of leadership role at an Optum or United or something like that, and their entry point might be like right?
Mm-hmm.
But what do these docs need to do so they don't get stuck there and then can use as like a stepping stone? Like, what have you seen docs do well to then advance their careers?
Relationships, performance. So use as an example. I did for many years. I'm very comfortable. I was the for two or three CMS audits. I was the face for United for the CMS audit. So I know not as well as I used to, but it's you have to, one, do your job well. Do your job well. Always do your job well. Two is there's an opportunity if someone says, hey, we have this problem with XYZ. So you have to have relationships with people. So you'll even know what the problems are, because what you see may not be what they're thinking.
Mm-hmm.
So I would say even be a little bit, and clinicians are a little bit, how do I say this? Clinicians aren't trained to be advocates for themselves. They're just, as I've seen over the years, when you go to medical school, you do your thing and you get some praise maybe, and you should be happy with what you get and you move on. In the outside world, you have to be a little bit of toot your own horn, but you don't want to do it too overtly. But you have to say, hey, market president, hey, could I have coffee with you? I'd really like to understand what's the craw in your, what's bothering you.
Mm-hmm.
What do you need help with? And if you can do that a few times and start to create a relationship and demonstrate performance, you'll be recognized as someone who is wanting to get out of that space. And I shouldn't say it that way. Like, you're not wanting to get out of that space per se, but you're wanting to grow and learn. And you might be given, this is going to sound funny, but a special project. You might be given some kind of extra thing to do. And if you're given that opportunity, seize it. Do not say, oh God, that's not part of my 8 hours, or that's not part of my day job, or I'm not getting paid for that. That is, you have that attitude, you won't be looked at for that next role. And so those are the two things I would kind of like: perform, excel, network, and if given the opportunity, take it.
When you look back on like all the various roles you've had, which of them like were the most fun, and what made it fun?
The one that I actually always tell folks, I get that question, is hospice. And the reason hospice was fun was that was the one time where nothing in the room mattered, and you were able to connect with a person and their family and their needs as they were going through something that, this sounds really bad, but a once in a lifetime event, right? So that was kind of on the more relationship fun. On the business side of it, I would actually say the time at WellMed and at United was fun. That was fun from the fiscally challenging performance execution, trying to make a thing happen, like coming up with an incentive plan for patients that's compliant, that drives a behavior, going through all of that, an incentive plan for clinicians, the system to close stars gaps. All of those things, like they're kind of fun when you're like sitting there going, what if we did that? What if we did that? And then you have really smart people in the room that say, you're an idiot. That'd never work because, you're right. Those
Yeah.
are really like, you love to have those people in the room because, you know, me, I'm kind of a dreamer and I'll go off. But if you don't have someone kind of balancing you, and so another kind of free advice is sometimes be the balancer, sometimes be the dreamer.
Mm.
What tell us about the transition from United back to Optum,
Yeah.
right? And then within that role, that's where we got to interact. Like, how was it like working a conglomerate with so many sideways currents and headwinds and tailwinds? And we always say working at Optum is like Game of Thrones. One day you're sitting there having a glass of wine, another day a dragon will come and eat your head, right? So like, walk us through what was that like from your experience?
I think it was, for me, it was getting back. So I've been at the payer for 3.5, almost 4 years. And I felt like I had learned what I could learn and what I wanted to learn on the payer side. So I wanted to get back to the care delivery side, Optum. And WellMed was an Optum entity at that point. And so I knew most of the folks had been around and had continued to interact with them because they were one of our largest delegated entities. And so we had great relationships. And that kind of that Game of Thrones reference, I kind of got used to it. It was just the way that I think, not just in healthcare, but I just think large organizations are wired for continued pushing, for lack of a better way to put it. If you're in an organization that's performance driven, expect to be pushed, to be uncomfortable, honestly. You should feel a little bit like you're going to get swooped. And I had someone tell me when I first started at United, at the CMO role, he said to me, when you get swooped, you will get swooped. You're lucky if you don't, but most people get swooped. Most people would use the dragon thing. That happens a lot. It has nothing to do with you. That has nothing to do with you. That has often something to do with the organization shifting or whatever. It could have something to do with you, but don't immediately think that you're not performing. Just be comfortable that things will change. It is going to be driven, and the strategy may change. And so, Reza, I kind of like, yeah, you're drinking a glass of wine, and if you get, doesn't mean that whoever was next to you they're gone, but you'll run into them again, I'm sure. And it has nothing to do with them per se. They wouldn't have gotten to the role they're in if they weren't driving performance, if they weren't an excellent person. In those organizations, that was my experience. Everyone that I worked with was top notch. Like there was no slackers. There was no one not outperforming. So
I mean, I know, at least from my N of one, when we tried to hire a national medical director where Alex came into that role, we had 300 applicants who were all standing CMOs, medical directors, national leaders, like for that one job, right? So
yeah,
like when you're at like the top place, there's a lot of talent. There's a lot of talent who wants to come in, and they're all slightly different in some way.
yeah, there is.
One of the things that's interesting for me, Efrem, is the difference between physician-led organizations and non-physician-led organizations in healthcare. Like in my own personal experience with various health systems as an ER doc, in general, if the hospital was run by a physician, I don't know, maybe I'm biased, but I thought it was usually run better than a non-physician. And I really enjoyed my experience at Optum, and Optum is very much physician-led. So like, what's been your experience? Have you noticed like a difference between physician-led organizations and non-physician-led organizations?
Yeah, I have. And I think non-physician-led organizations need to have leadership that is open to physician-clinician input. I think non-physician-led organizations tend to be a lot more diligent, have a lot more rigor, and be, you could almost say, draconian Reza, like the Game of Thrones, around, hitting the mark. They also, though, are driven, as long as you can support them with a clinical or empathetic mission to make sure that you're that voice saying, do the right thing, do the right thing. In the physician-led organizations, you don't have to do that as much, right? It's kind of ingrained in what the docs do, if you will. What I found in the physician-led organizations, they're a little bit, which as clinicians, it's more comfortable. I'm not going to say lax. They're a little bit more easier to relate to. Maybe that's a better word. Like you're far more comfortable talking to the CEO that was an ER doc, that had some shared experiences that you did, probably than an MBA from Wharton, that was your CV, right? I mean, it's a relationship thing. But I think as long as the organization is mission driven and understands, it has clarity, like that's one of the other things that I found. If the organization lacks clarity, it's really hard for everyone else. And what I mean by clarity is, we're going to hit this target financially. We're going to hit this, quality score. We're going to boom, boom, boom. And that's what we're doing. No ifs, ands, or buts. That's what we're doing. And if you can get to that point, in my opinion, you start to just feel, okay, I know what we're doing, right? They're talking about that thing, but this is what we're doing. And I know what to do. So.
Awesome. So as we wrap it up, I'd love maybe your thoughts on, like, what are you excited about in terms of the future of the US healthcare system or AI, or like, I'm just curious.
That's actually what I'm both excited and worried and trepidation and all of those things with. So if you actually go, and you guys probably know this, there's still people in this country that use paper. There's people that still fax. There's still people that have some of the most antiquated systems. Like who does that at scale? Like we do as clinicians. So that's one thing. And then you think about the advancement of technology and how slow we are to adopt, but how much is there. So if you just think about kind of enabling clinician decision making, enabling and supporting physician and patient interaction and engagement, patient decision making, all these things that are right at the cusp, I think those are super exciting. They do concern me because without appropriate guardrails, which scares me, but also we may put too many guardrails and slows us down again. So we're still faxing. I think that's the opportunity. So I think in healthcare, that in the next 5 to 10 years, 3 years, 2 years, AI and technology should advance tremendously. Now, I said that too in 2005 and 2000 and 2010, and I still walk around in some of these offices over the last few years, and people are still faxing and they're still on paper, and it's really mind blowing. But
Efrem, my final sentiment is around people and community, right? So like we've developed a friendship. There's a lot of population health people who've become friends over the years, and then there's local communities. Like, so right now you're working at a Chinese focused medical group that has an amazing community. Before, you were in a tight-knit organization in San Antonio, right? So what is the common theme of building a community, nurturing it, and having that special sauce that goes beyond what's on the decks, to drive real value for patients?
I think you're saying it, Reza. It's the community. It's the clinician-patient interaction in the room, in the community, understanding what's happening in the neighborhood, if you will, and being able to have that relationship, that trust, that you can't get otherwise, right? It's really easy for me to look at some numbers and say something, but until you truly understand what's happening, which is why what you're describing is so valuable. Like you can't recreate that. Like it doesn't exist unless you're there. So community-based and understanding that is extremely, and when you move too far away from it, it becomes increasingly difficult. to not just understand, but subsequently influence, because you're making statements that potentially don't have, or you're trying interventions that potentially won't work because you don't really understand what's happening. That doesn't mean to say that you can't, talk to folks and really get the meaning and get the gist. But that's the experiences and being open to those kind of dialogue. So, yeah.
Amazing, Efrem. Thank you so much. I really appreciate you sharing your story. And I had no idea that you had done so many different things and that you had started your essentially entrepreneurial journey during residency.
Yeah.
That is amazing.
Yeah, it was fun, man.
Really
it was fun.
amazing. Thank you so much.
All right, guys.